Yeah, good afternoon, sir. I am Dr. Srinivas Kumar here. I was joined by Dr. Ferank and Dr. Sanjay, Dr. Raghu, Jabir Ali, Abdullah Kuti, and many others, sir. Over to you, sir. We can see you and probably present your case.
All right. So good afternoon, everybody. It's always a pleasure presenting to this august audience. So we are in Ruby Hall, Pune, and our first, rather today's case, is a 53-year-old gentleman, non-diabetic. He's hypertensive, and he has COVID and MI both together. I mean, he had MI, was tested for COVID and was positive. He was in some peripheral town, and we suggested we wait because he had no pain and ECG had settled very well. So LV function is good, ejection fraction is 55%, minor inferior hypokinesia. So we will show you the right coronary angio, run number 1, and we are with simultaneous Judkins catheter in the left ostium. With me is Dr. Makhre and Dr. Salil and the entire Ruby Hall team. So this is a simultaneous injection together, and you can see the distality of the right artery. Next view. Next view. So, you know, the filling of the right coronary is all the way up. So looked like a focal lesion in the right coronary artery. Probably would need something like a 33 length stent. Okay, you want to add anything here?
Yeah, this is what we have done, the contralateral injection, as the rule suggests, that first you inject the contralateral vessel. So by the time you follow it here on the ipsilateral side, your ipsilateral injection comes through, so that you know the correct assessment of the CTO segment.
So we are with AR1, and next slide. Next run, we come with a Gaia wire. This is Gaia 2, and there is no real support from behind except for a decent position of the right guide. So Gaia is making progress on its own. It is guided by the left injection.
Next.
Dr. Hiremath, did you use a microcatheter?
We did not.
No, microcatheter is there, but it is not brought in as yet, but it is in the guide catheter.
Okay.
Okay, next.
Sir, which are the situations in which you tried first, because the faint antegrade trickle, then only you will take a Fielder XT type of wire. Otherwise, if it is definite CTO, you directly go for stiffer wires. I think you thought this is an older occlusion,
yeah,
that's why you straight took Gaia.
This is from March to today, about 4 months.
Okay.
And definitely, in fact, on the ECG also. Next.
Okay.
So the left is sort of guiding the progress of the wire. We thought we are in good position now. Time to bring in a balloon. So you can actually see the balloon come in. This is a 1.5, 15 balloon, Zion.
No, it's
Abbott balloon, mini track. And we had little difficulty in pushing it, but ultimately it went well. Next. So the whole length is now dilated with 1.5 only. So decent flow, and we probably see the length also.
Sir, for sake of everybody, with such tough lesions, what is your first balloon of choice for difficult entry purposes? Like here you have taken mini track.
We started with 1.5. It would, if it would not cross, then possibly we would have taken even the Mic Nano 0.85.
Dr. Ferenc, what do you use there?
What we use in Germany in our center is usually Ikatsuki balloon from Japan, or Rurai from Terumo, and Sapphire for Obersnier. This is our first choice. If nothing is running through, so usually we start with Ikatsuki. It's 1.06 millimeter long, and if Ikatsuki doesn't work, so then there is no option for crossing. That's my personal opinion.
We generally take rail balloon of Taramo, sir. It's quite
Go back
very
to the
good
previous
Prakritic
run and
and
continue to
process.
run.
Colleagues are doing here very nice progress, and you can see now how big this artery is finally. So it makes definitely sense to open this artery. My first choice of wire will be probably to try Field XTR and then Gaia second or something like this. But Dr. Hiremath is very skilled operator. He is right guy.
So over Gaia 2, we have placed a microcatheter through which we are now putting a, this is a hydrophilic wire, which is placed well distally.
Yeah, perfect.
This is after some more dilatation. Run this again and freeze it.
So now we have impression there is also very distally, probably, I don't know, maybe spasm, but it looks like a significant distal stenosis. So you have to probably use 2 long stents.
Yes,
Exactly.
I think this is what we also discussed, and we are now ready for 2 stents.
Next.
We of course needed to dilate the distal part well.
Yes.
So we are dilating with a 2515 NC balloon on high pressure.
Next.
And
Dr. Hiremath, you do a very nice job, definitely perfect. What is maybe important for younger colleagues, for younger interventional cardiologists, so how to estimate the vessel diameter for this distal segment. So it's 3.0, 2.75, or maybe 3.5. So would you suggest to go here with imaging, or would you go now direct with a stent? And there is some kind of tortuosity. Would you consider to use also here guiding extension like Godzilla or whatever?
so we were in what you are also thinking, 2-stent strategy. So the distal part of the lesion is now dilated, and this is a 48 length Zion stent. You know, the guide stent was not tracking very easily distally.
Next.
Despite guide catheter adjustment, it was quite difficult to get it further.
Yeah, so what is now your next step? Would you take another extra support wire, so body wire, or would you go with more intensive prodilatation, or would you take guiding extension, guideline or Godzilla or telescope, whatever you have?
We got a guide into guide, a telescope
Right
catheter.
catheter extension, telescope.
This is a Medtronic introduction just a couple of weeks back. So on its own, the telescope you can see coming up to the mid portion.
Yeah, perfect.
Then we
what I do usually, I usually take balloon and
Yes.
3.5 or 3.0 and go over the balloon step by step and more distally, and to avoid huge dissections, whatever.
Yeah.
Actually,
But,
this is what we did for earlier guideliners, Guidezilla or guideliner.
Yeah.
But up to the telescope, people were telling us that it can go a long way inside without.
Yeah, that's correct. That's really.
So we just tried that. It didn't work to a great extent, but once we gave a support, it moved in very easily.
Yeah, perfect.
So as the balloon is deflating, we are sort of rolling the telescope on that, and this is the 48 length Zion expedition.
Now it's perfectly demonstrated, Dr. Hiremath, how easy PCI or stenting positioning of the stenting can be if you have perfect guideliner or telescope position. So now it's easy and safe.
Dr. Hiremath, is there, do you feel a real difference between a guidezilla and a telescope?
Well, this is our first use of
Yeah, but I
telescope.
find it very promising because at its own it could go up to the mid RCA where our previous stent was getting stuck. So
It's considered to be
yeah,
more
afterwards
flexible.
we needed to do the balloon anchor technique, and with the balloon anchor technique we could pass it as distal you can see.
Definitely it is more trackable and kinking chance is less,
Yeah.
and it tracks like a regular balloon going over the wire. That way it is a significant improvement over Guidezilla. I am not too sure when compared to Guideliner how it works, but definitely with felt it is slightly better trackable and less kink risk, more of less kinking is less. So I think
it has got extra support with a platform.
yeah.
So this was after the distal stent was deployed. It is 348 and the balloon was taken to about 14, and this is the
Next,
position.
next, next.
This is a 3528
Giants expedition again.
again Giants expedition. So whenever we are taking long and extra length, extra long stents, we need to size it properly.
Next.
So after putting the second stent 3528, the whole length is post dilated with a 3 and 3.5 NC, 3 in the distal stent and 3.5 in the proximal stent. So these are some of our final pictures of the right, and this is the without wire. So you can see a lot of blush at the distality. So hopefully the LV, which is well preserved at this stage, continues to be good in future too. Any comments? I mean, this is a 4-month-old inferior wall infarct and a totally occluded right coronary artery. And
so from my perspective, very good decision to open this artery, and I'm quite sure there was option for recovery of LV function. And I think, Dr. Hiremath, your point is very much the point how important is to perform post-dilatation with NC balloons, you know. So it looks sometimes after stenting by angiographic view very nice, but we know from OCT data and from IVUS data in around 40% of cases there is still malapposition. So from my perspective, post-dilatation is a must, and I do this in 100% of cases. So at least in all my patients with stented segments, they got finally post-dilatation with non-compliant balloons. I think this is really very, very important point.
Dr. Farang, would you prefer doing an OCT in this case? It's 2 long stents and it's essential to optimize the
Not really. I think the stents choice was perfect. Post-dilatation was done by angiographic view. It looks perfect. From my point of view, in this right coronary artery, I would leave it like this.
I think when the places where imaging is not available, as Ferenc said and Dr. Hiremath are shown, post-dilatation with a quarter size bigger balloon with going to high pressure is mandatory, especially whenever the stent's lengths become bigger, more than 28. Generally, it is always better to again post-dilate with a bigger balloon, especially in the center. Otherwise, sometimes you could have hourglass effect and the stents less expanding at the site of lesion. So that is very well demonstrated, and the final result, that's how is quite good. I think we are going to left sir now.
Yes, so we are with EBU 7, and you can see the circumflex as it is running in the AV sulcus. It is critically narrowed in the mid and distal portion and moderately narrowed in the proximal portion. So the plan is to go for circumflex first. The next vessel that you see is actually a diagonal, and this is the LAD. So LAD proximal to the diagonal 2 is showing a moderate disease. The idea is to have an FFR on the LAD. Next view, and in spider view you can see the diagonal showing a disease right from the osseum.
And this diagonal is coursing like a OM in the distal part.
Yeah.
So
You
we
will
will
say the Ramus-like vessel, the
But
first
it is
diagram.
clearly arising from the LED.
Yeah.
So we will go for the circumflex first. Contrast ready. Small. So this is that same run through hypercoat. Small.
Yeah.
I can't see it. Okay. Come to this view.
Srinivas, we will continue with the circumflex and do the FFR. In the meanwhile, if you want to go to the other center and come back to us. Are you with us, Srinivas?
Yes, sir.
Okay. So we have
How
done
much
that
are you?
circumflex distal.
We'll
It's
validate a very low atmosphere.
we are doing a post dilatation. We'll show you the images, and then after that we'll do the FFR for the LED.
12. 14.
Hiremath, which wire finally did you use for the successful crossing of?
This is run through hypercoat.
Oh, nice, really very good.
Boost or fluorocine.
Run-through has become most workhorse wire in most of the labs today. It looks like
Yeah, it's a
quite
high quality wire, definitely.
quite good wire.
I need one more. Huh?
Boost लागेल बेटा.
Okay, boost.
Frank, is still out the most preferred bifurcation strategy when you are
Stent
going to
boost
go
there
for
on
a
that screen.
acute stent strategy in Europe.
18.
Okay, get me the microcatheter. Hello.
Europe, usually we try to go
The right one. Right
in,
up.
around
You want to
20
do LED first? Okay.
minutes,
Yeah, I do
double
LED
stent.
FFR now.
So in Europe, and I would say
FFR wire.
kind of things
Sir,
will be done by a lot for tap. Maybe you heard this story, so
You're ready for picture of this?
very
Contrast ready?
in Europe.
Okay, contrast.
Main study
Contrast.
process with only 5% adequate. I think
Can you increase the sound?
from my perspective, the best way to cover that one is the easiest way is plot.
So,
Plot is also perfect, but much more challenging and to have
Doctor-
much more prices. It also play, I think, important role, not only because of more costly or expensive, but also according to the more use of plastic, etc. Then I would will
zero के लिए
proceed with plastic. I think we have to do all these steps to avoid much.
Hiremath sir, you were telling something, sir?
yeah, I mean, we have put a stent which is 33 length, and there is a lesion proximal circumflex just after the branch, OM1 branch. So that is a discussion issue, whether we should stent that or whether we should do an FFR to that proximal lesion. What is your suggestions from the audience?
No, it looks like middle six a little ectatic. If you do FFR, sometimes it could come negative also.
All right.
Where is the proximal stent ending? There's in the middle six, we couldn't see that correctly. If it is very close to the lesion, generally it tend to cover. But if it is away, the lot of normal segment in between that proximal lesion versus stent, I think you can do FFR in this side.
Yeah, that is our plan. We have about 8 to 10 millimeter gap between the stent and the lesion, distal end of the lesion. So before that, we will do FFR on the LED. Can you show us the LED pictures in epicranial? Okay, can we show them the LED pictures? Just 1 second. Just show the LED pictures.
Equalize करता हूँ थोड़ा सा.
So the LAD in the proximal portion, proximal to the diagonal 2 branch, that's under consideration. Looks about 50%. If FFR was not there in those early days, we used to leave these lesions behind.
Diagonal looks tight, sir, but proximal LAD looks not much important, at least angio.
Yes. So Dr. Makhay is with the FFR wire, right? Makhay?
Yeah, I'm with the FFR wire.
Huh.
So,
Equalization.
yeah.
So you are in a small match.
Okay, now wait, let me take this thing out. Introducer.
Just
Give
focus,
some
focus on the
NTG.
fingers.
Hiremath, is it a little? It seems to be a little tough lesion to for the FFR wire, isn't it?
No, FFR wire is tough. It's not that
It's
lesion is
tougher.
tough.
It
Is not like a run-through wire. You
Is
always need to
equalization
handle
done?
Equalization is done, no?
It's a bit difficult to manipulate
Yeah.
FFR wire through these tortuous lesions.
What Zabir is telling is a very valid point. You should not
Okay, go to
consider
epicranial.
FFR wire is totally equivalent to like a routine workhorse wire.
So
Need to handle it.
we have done the equalization. Can you see the FFR on the screen there?
Yes, sir, we can see it.
We can see.
So we have done the equalization. Now we are moving forward. Next small contrast.
Which modality you prefer, intracoronary or intravenous?
Intravenous sustained 3 minutes hyperemia.
Are you going to do a RFR or a IFR first and then going for FFR or only FFR?
Only FFR.
Actually, what we have observed is intravenous actually less chances of getting a fallacious value. Because
Correct.
intracoronary sometimes when you're trying to change the 3 ways this side that side and you could
Yeah,
get a fallacious value sometimes.
I agree. I trust more of the intravenous. Start adenosine, please.
Only thing is intravenous consumes lot of adenosine. Hospital owners may be a little worried. But intracoronary it is a lesser thing. But from patient point of view, result point of view, I think intravenous
Adenosine.
reproducible result.
I think we all now consider intravenous continuous
Should we
infusion
start?
as the
Start adenosine,
Yeah.
please.
Start.
gold standard. And
Yes.
Yeah.
the errors are much less with that.
Hey, just focus on the
Dr. Hiremath sir, we also see Dr. Gary Meds and Kirti Punami joining for the next session. And anything, Dr. Gary sir, any comments on this? Welcome to TCT India. Thanks for joining. We'll just finish these live cases and go to your session, sir. Just another 5 minutes more.
Sure, thank you.
So we are seeing figures like 0.78, 0.79 on the LAD. And adenosine has just started, about 1/3 has gone.
Oh, then it becomes important, sir. Generally, once
Right.
it immediately in the first half itself it has gone less, it is more likely to. But once it goes to a lower level, generally it stays there. 0.79, 0.8.
So what is the advice from the floor? Do it or wait?
If values are definitely positive, like less than 0.75, there is no ambiguity. But if values come in between 0.75 to 8 and keeping the clinical scenario and angiographic appearance, lot of things, we need to take a decision. Angiographically, it was looking less, and but only the issue is here is a proximal LAD. Important thing we have to be absolutely sure. Is having angina, sir?
I believe this
No,
is
no.
the
Yes.
LAD region, which
Any
has
pain?
definitely an impact on prognosis for this patient. So if we have here such result, we have to handle.
No, if FFR comes 0.81, what do you do, Farag?
Yeah, we are actually 0.79, 0.80 as you can see.
Yes, yes.
So it is really a very borderline.
I mean, if I can make one comment.
Sir,
So,
please.
Yeah, Gary, go ahead.
sure, you know, it's very difficult to normalize an FFR after you've treated an LAD. So you've got 3 potential regions for the FFR being borderline: proximal disease, distal disease, and the stent itself. And if you look at the entire literature, having an FFR like this after stenting is much more common in the LAD than in the circumflex or the right. So you really should also do a careful pullback, making sure that this is localized to the proximal vessel before you jump when treating the proximal vessel, and that it's not, perhaps that the stent is not fully expanded.
Dr. Gary, they didn't do stent to LAD, they did stent to RCA and LCX.
Oh, I see, I see. I'm
They are
sorry.
studying, yeah, they are studying the LAD lesion first.
Oh, so
We'll take the
I came in late. I thought they'd sent it to you.
Finish.
Yeah, that's right.
So in this case, it's a borderline FFR in the LAD.
take picture.
And when you have somebody with an FFR in the, in the 0.8 range, they tend to do well irrespective of
So we'll leave it.
whether you treat them medically or with
Take
vascularization.
out the FFR wire.
To the circumflex.
Huh?
We should take this to the circumflex to assess the proximal
But
circumflex.
but they should also do a careful
Spider, please.
pullback and make
Spider.
sure there isn't some occult
Because-
disease in the left
Spider.
main.
Sir, Michael, sir,
Spider.
what sir is advising is
Spider.
that take a pullback and see that
Hey, wait.
point
Okay.
drifted.
They want you to take a pullback.
Okay, be live on the this thing.
Yeah, so that
Epicranial.
we'll see exactly where the pressure is, drop is happening, where it is becoming normal.
Okay, I'll.
Okay, enough.
Okay,
Because
That's fine, we are much distant to the lesion, you can come back now.
Start withdrawing.
You can keep the FFR on, please, on one small screen, FFR on small screen, and then angio on a big screen.
show the
Show
FFR.
FFR on the screen, please.
Yeah, okay. We are seeing, sir, now, go ahead.
So, so it was all the time more than 0.9.
So that's what is the problem. It's not they got stepped up only proximal to the lesion. There is, I think overall the decision would be to leave it, sir.
Leave it.
Okay.
But what is the wisdom from your end?
It's only 0.9 and angiographically also it was only an intermediate lesion.
Yes.
I think once we do FFR, we shouldn't fall back on angiography because angiography is showing a sort of moderate stenosis.
And the FFR is 0.9, we can comfortably leave it.
Though we showed you FFR which was 0.79, 0.80.
It is 0.79.
Yes, 0.79 and 0.80.
So it's exact borderline, then a tough call to take.
Now we are seeing assessing the proximal LCX, sir.
Yeah.
Yes, just show the
Show it live.
last picture of the LCX.
Yeah, we saw that, sir. We can see the FFR now.
Last picture,
Okay.
last picture of here on the cine, main cine. Last picture after stent to the circumflex. Okay, freeze. So you have a stent in the mid circumflex, and now we are checking the FFR on the proximal lesion.
Okay, now we'll be doing the FFR for the circumflex.
Check your.
And what's your decision on the LAD? Are you going to stent the LAD or leave it?
Leave it.
You all told us leave it, so we are going to leave it.
Start adenosine.
We'll leave the arena after the live.
Yeah.
I think don't forget this patient got during this procedure. You open the right coronary artery, so it's now open vessel. You open nicely distal circ, so we definitely improve perfusion in this patient dramatically.
तो proximal lesion दाखव ना परत एकदा.
And order the patients in few months back.
हाँ.
Generally, sir, if you, before adenosine, if it just above 0.95, 0.98 like this, even if you go adenosine, it could become like 0.9 or 0.85 maximum. It will generally come negative. But by and large, baseline, if it already drifts to 0.9, 0.85 like that before adenosine, then after giving adenosine, it will become important. Here it looks like baseline is just 0.9. Now after adenosine, it could go down to 0.85, things like that. You started adenosine now?
Yeah.
Yes. About 30 seconds now the adenosine is going on.
Generally, after IV, we start getting response after 1.5 minute of infusion or so, and it goes down to some level and then it sticks around there even if further infusion also.
So what you get the good steady state rather than those jerky movements.
Yes, yes, yes. That's the advantage of
That adds to
having
the
an intravenous.
confidence of what you are doing.
So actually we are giving adenosine through femoral vein. So it's a
Okay.
central line, not in the peripheral vein. So you would probably see the effect almost immediately.
Okay. The lowest we saw till now is 0.85.
Get the wire run through hypercourt. We'll start doing the diagonal.
We'll take 25 or 275
What?
cutting.
275. So we are given about 2/3 of adenosine, and
Hey, Brady.
Yeah, bradycardia.
Yeah.
Stop, you can stop.
Stop adenosine.
no, let it continue. How much is gone?
I think even this came 0.83.
Yeah.
So we leave it, right? What do you suggest?
Yes, sir, because if you had to follow FFR, probably we'll leave it.
That's a nice answer, huh? If you follow FFR. So
The idea of doing is it to follow it, no, sir. If you are if you are believing it, then probably you should
no,
leave it.
so but then you cannot say if you follow FFR. When
No, you should leave it then.
Say,
when you
by
do
science,
FFR,
we
it
leave it.
means you are going to follow.
Yes, sir. Yes, sir. I correct it. If your FFR
But-
came more than 0.8, you should leave it.
So I'm removing the FFR wire.
So
You
FFR.
can see the drift, sir, for the sake of everybody, what Gary was mentioning. While withdrawing at that particular point
Wait,
where the
wait.
lesion is, if you come back, the transducer comes proximal to it, suddenly it jumps up. I think now it
so
is
now
gone
it is
up.
0.94.
So that means what we have done is reasonably correct, and that again proves us that what we did is right. Thanks, sir, for excellent demonstration of a triple vessel disease. And with LED not being there, many of the times there is no point sending this patient for surgery. Many of the times in periphery it is written as triple vessel
Just
and people keep sending for
Vikas,
surgery.
Vikas,
If the LED is not
just show them
important
the
and only
diagonal.
RCA and LCX, you effectively shown that we could revascularize by PCI. If any final words, sir, Dr. Hiremath, before we break, sir?
No. We need to look at the diagonal. Diagonal is quite important vessel,
Spider.
and
Diagonal will be positive, sir. Angiography wise, it's tight, no?
it's tight. So we are going for diagonal now. I think
Because,
we'll have to leave you guys.
yes, sir. Is it okay?
Yeah.
Yeah.
Thank
If
you.
it comes positive, you would stand diagonal, otherwise you leave it. That's the plan. Thank you for effectively showing a multi-vessel PCI very well demonstrated. Initially it was RCS CTO, and then you showed effectively how to tackle LCX, and now also FFR based decision of leaving LED. Thank you, sir. Any final words before we break from you, sir?
Thank you for the opportunity. It's a big pleasure talking to somebody like you and the audience there.
And Gary Mills as well
So
as
this was multi-vessel, and the right had already given him an infarct. The two vessels, the LAD and the proximal circumflex, we said no to dilatation based on the FFR. And now we are going for the diagonal.
Thank you, sir. If
Namaste. I am Dr. A. Srinivas Kumar, Senior Consultant Cardiologist, Director Cardiology and Clinical Research, Apollo Hospitals, Hyderabad. This video brings to you the best wishes from Fax Foundation, TCT India, South Asia 2021. In our live case learning series, we are planning to discuss on the interesting case of multi-vessel PCI demonstration which was done from Ruby Hall Clinic by Dr.MS Hiremath sir and Dr. C.N. Makale. What we've learned in this case was patient had initially COVID infection, and then few months back he also suffered with inferior wall MI. As patient was stable, Sir has advised them to keep on medical therapy for some time, And then once the COVID got controlled, then he came for further evaluation and management. This is what is a strategy which was generally followed for inferior MIs and smaller MIs in COVID era. But unlike that, if a patient has a large MI, anterior MI, hemodynamic instability, where primary PCI was required immediately, we follow level 2 COVID precautions, PPE kits and other things, and do the procedures if required, taking all precautions to have a negative airway management in the cath lab, and also protect all our cath lab staffs, and to keep the procedures to as minimum as possible, time as possible, and also have, if at all patient is breathless, probably needs to be done, intubation needs to be done before rather than the cath lab. These are some of the points which I thought could be stressed in these COVID times where we are dealing with such acute MI patients with PCI procedures. Coming on to today's case again, initially the RCA was a reasonably large vessel which was occluded in the mid segment. We started off with the Amplatz catheter, and then operator like Dr. Hiremath, who's quite experienced, straight away started with a Gaia type of wire because it's 3 months plus old occlusion. But he took the help of microcatheter, which was initially kept in the guide catheter. And then once the Gaia made little progress, then the microcatheter was advanced, and immediately the wire was changed to regular workhorse wire, like a run-through wire. And then serial balloon dilatation, the smaller balloon and then the bigger balloon were done. And then because the lesions, they also look distally, also they look like lesion from apart from the mid segment. A long stent of 48 mm was selected, and then there was difficulty in tracking the stent in spite of manipulating the guide catheter. Again, the telescope, which is a new guide extension catheter launched by Medtronic, was used, and that catheter could easily go up to the mid RCA where the lesion was holding, and then the stent could be delivered easily. And that's how we have also seen how the telescope catheter works in this case. And later on, after the stents were deployed, the highlight of the other important aspect which needs to be stressed is not only the focal points of underdilatation in such large stents. It is usually advisable to take little bigger sized NC balloons and dilate throughout, leaving the edges, so that is to avoid the hourglass appearances developing in the stent, and then probably proper approximation and expansion of the stents could happen. This aspect was also very well highlighted by Dr. Marcelo Ferenc, who was moderating on this side, who said in all his cases of long stents, he would do post-dilatation in 100% of cases. That's how the final result was optimum, and the flow was very well established. Sir also has demonstrated initially to take a contralateral injection from the left side with the 5 French catheter that helped to delineate the extent of the retrograde filling of RCA along with the antegrade injections, though that was not required once antegrade balloon dilatations were done. But initially it helps us to understand the extent of a block and how the distal vessel architecture and distal vessel anatomy disease is there. So that is important. Another important learning point, how to use the contralateral injection, was also effectively shown. After the RCA PCI was done, then we came on to the left side. The left side has a LCX has a mid and distal disease and the proximal milder disease. LAD showed a proximal mild to moderate type of disease, and the diagonal, which is again bigger, had a tight stenosis. Then initially the left circumflex was tackled, mid and distal portions were dilated and stented, and the proximal portion from the stented segment, there was about 10 mm gap, and the discussion was whether to stent that proximal vessel or to leave it. The decision was to do FFR and then assess the LCX proximally. The FFR came negative, so proximal LCX lesion was left. Anyway, an angiography also was looking mild, so it was left alone for medical management of the proximal vessel. Then LAD was also assessed. Then LAD, RFR values, FFR values were seen, and then LAD results were baseline versus post-adenosine did not come important. That's why the decision was taken to leave LAD also on follow-up. Discussion also raised a point where intracoronary versus intravenous adenosine infusions, and finally all concluded saying that probably intravenous infusion gives more smoother dilatations, and rather than if you do intracoronary, probably while moving the three-way catheters opening, closing, there could be artifactually factual errors coming rather than smooth hyperemia which comes through intravenous. But only disadvantage of intravenous would probably more of adenosine is consumed while during the testing. And Dr. Hiremath sir mentioned in the lab that they were giving adenosine infusion through femoral vein, so it reaches faster, so the immediate effects is almost seen immediately. And that's how the physiological assessment of LAD showed that LAD lesion is not important, and the proximal L6 also could be left, whether the mid and distal L6 was tackled effectively by stents. And then it was also assessed how the mid and distal L6 stents were seen in this OCT guidance, and then optimal expansion was sought. Then in the diagonal, again had a tight stenosis, which in fact would be stented at the end of the procedure. So thus, if another important aspect of decision making which was stressed in this case was if a patient has, though semantically it could be triple vessel disease, but if the patient does not have a significant LAD disease or a borderline mild proximal LAD disease, if the surgeon gives lima, limas could get occluded. And that's how, and though semantically it could be triple vessel disease, but if the LAD is not involved, there is no point sending these patients for surgery, and probably all these patients could be effectively managed by multivessel PCI. And how to tackle this and how to get optimal results with imaging and physiology guidance was very well demonstrated. The physiological guidance, another point which was stressed and shown very well, was the drift patterns, how the FFR values suddenly become normal once we come proximal to the lesion, was also effectively shown. And this final, what we all aim to do is to do what is good to the patients and what is optimally to be done. So be it right coronary artery CTO. Another point which we need to learn is the most toughest lesion, because CTO was opened first to stabilize the patient and later on went on to revascularization of LCX, and then finally LAD checking was done. With this, I think a lot of learning points which were effectively demonstrated by Dr.MS Hiremath sir from Pune. Hope you all like this live case transmission and enjoy these live case learnings too. Thank you. Yours, Dr. A. Srinivas Kumar.